What is it important for you guys to think about when you're doing an assessment, specifically medical assessments? We're going to do a lot of focusing on trauma, but today we're going to focus mostly on medical problems. Some of you guys might be more familiar with trauma, especially like if you're military medics, where it's pretty much exclusively trauma. And if you're a city side medic, it's almost exclusively medicine. That's just one of the main separations between those two worlds. So, like I was saying earlier, the most important thing is just asking questions, lots of questions, and that's what helps. Now, the best way to do that is just through repetition, right? Having lots of patient transports, having to perform a lot of assessments. Assessment is an ongoing process and not a one-time event. Injured and ill patients are dynamic. They're going to present in lots of different ways, and ever-changing patient positions or conditions can pose ongoing threats if they're not rapidly detected and treated. So you guys might remember back to the NREMT guidelines when you originally got your certs or when you're going through that. We have medical assessments, we have trauma assessments, and then we have all the individual skills like BVM, intubation, all those things we do. Realistically, all assessments are broken up into a couple different things, right? A scene size up, an initial assessment, more detailed further assessments, or if it's trauma, doing a trauma assessment, and then ongoing, right? Repeating vitals, repeating assessments, checking your interventions, seeing how things are going. Sorry for the formatting in this thing. We'll go over this starting out. So scene assessment is how we start off with. So realistically, what that means is we need to be able to assess certain things about your patient before we even touch our patient, right? As we're responding to the event, as we're walking up to the patient, we're looking at them, we're watching them, we're seeing how they're presenting, right? What do their skin looks? In fact, I would say this, the most beneficial thing you can say is maybe you guys are familiar with the pediatric assessment triangle. Maybe you guys remember hearing about that. Pediatric assessment triangle is a visual representation we can use to look at pediatrics and kind of get an assessment about how they're doing just by looking at them. This works really well, not just for pediatrics, but for all your patients. The pediatric assessment triangle is their work of breathing, their skin condition, and their mentation, how they're acting, right? So are they altered? Is their skin condition look healthy? Are they really working to breathe? Like, how do they look when you're approaching them? Those are really big indicators whether this patient's going to be big sick or little sick. If you guys are doing these cognitive skills, all your patients are going to be big sick. Realistically, in the field, they're not going to be big sick very frequently. So we need to make sure BSI, scene safety, number of patients, right? We need to determine if we're going to need additional resources. We might need more ambulances, or we might need more people. It might be an MCI, a mass casualty event. And then we need to decide, does this patient need to be C-spine immobilized? Was it a fall, or is it unknown etiology? They're on the ground. If we don't know, we need to assume that they might have hurt their back or their neck. All right. Then we, hold on. National Trauma Triage Protocol consists of 4 components: vital signs, and the anatomy of the injury, mechanism of injury, means was it like, were they hit by a car? Was it a car accident? Low impact, high impact, gunshot, stabbing, assault? What's going on here? Any special patient considerations, obviously including the ABCs. We measure things like the Glasgow Coma Scale, which we'll cover a little bit later, systolic blood pressure, respiratory rate. We want to make sure things aren't outside the regular rates. So we know that GCS is a scale from 3 is the lowest score you could get to 15. If you guys don't remember GCS, don't worry, we're going to go over that in more detail tomorrow. I can't remember if it's later today or tomorrow. Blood pressure, again, we're mostly concerned when they're hypotensive, under 90 for adults. For peds, it's a little different. You guys might remember it's 70 plus 2 times their age. So a 5-year-old would be a minimum of 80, and that would be the minimum acceptable blood pressure for them. For adults, though, it's going to be about 90. It's much less than that, and we're not really going to be able to perfuse the way that we need to. And we'll talk about perfusion here in a second. Finally, the respiratory rate. If they're breathing really fast or really slow, they're probably in shock. Now, most people don't necessarily breathe 12 to 20 times a minute. In fact, I'd say When we're sleeping, we're breathing as few as 6 or 7 times a minute, depending on how healthy you are, how big your lungs are, different things like that. There's going to be lots of things that we're talking about here when we're talking about penetrating injuries, chest wall instability like flail chest or pneumothoraxes, crushing, degloves, mangled, pulseless extremities, burns. We're going to go over all these in more detail later. All right. And basically, we're using this to try to determine whether this patient needs to go to a trauma center or not. Now, trauma center patients are different. So if you guys have never worked in EMS, then trauma patients or trauma hospitals are so hospitals are classified based on the level of emergency they can handle at any time. The highest classification is a level 1 trauma center. This means they can handle everything 24 hours a day, 365. They have someone on staff that can handle emergency traumatic surgeries. They have orthopedic surgeons on staff 24 hours a day. It's very hard and expensive to maintain a level 1 trauma hospital, so you frequently will not have very many of them in a city. Bigger cities might have multiple ones. Most cities only have one. Call it a, we call it, hold on, a roll 3. Interesting. I've never heard that one. Is that like a military terminology? I just, or is that like specific to where you work? Interesting. I've never heard of roll 3. So that would be the highest like caliber trauma hospital. It seems to me in the military, everything should be a trauma hospital. You know, everything needs to be a level 1, but probably has to do with, I'm sure the military uses slightly different distinctions on how they do that. All right. So kids also, we're going to want to be taking them to pediatric capable trauma centers. Almost all trauma centers will be able to handle peds no problem. If there's a pediatric hospital here, then it's going to be this, the preferred place to take the patient. However, you can always take pediatric patients to adult hospitals. They'll be able to treat them just fine. All right. And then any special patient system considerations, burns, pregnancy, or anything that you think might be worth considering. We're going to talk about burns and pregnancy later on in this course because those are very specific things, and we'll explain what those do and how those are dangerous to you. Now, in general, when you're approaching a patient who's sick, the best thing you can do is form a general impression, ask them a couple key questions, try to figure out the idea of what's going on here, and then ABCs. As long as we can control the airway, breathing, and circulation, our patient's going to at least make it to the hospital where they can undergo more advanced care or a more advanced assessment. It's not always going to be ABC, though. In fact, but it was only one case where it's going to be CAB, which is for cardiac arrest. If they're pulseless and apneic or not breathing, now we start with CAB, C being compressions. Now, C still means circulation, but in this case, it means compressions, right? The problem with CPR is that our heart is no longer mechanically beating, or it's not beating enough to cause perfusion. This means that we need to mechanically press on the heart in order to get the blood to flow around. So that's the biggest priority. In fact, it is so important that every minute your heart is not beating, your chance of surviving is cut in half. After 2 minutes, you're down to 25%. 3 minutes, you're down to 12%. We have a 7-minute response time in EMS here in San Diego. If no one's doing CPR by the time we get there, the chance that we're going to get them back is pretty much 0. As far as vital signs, pulse, respirations, skin signs, blood pressure, pupils, and SpO2 are the most important ones that they want you to be getting every single time. Probably an EKG assessment as well. We'll go over this. Pulse ox is now considered the 6th vital sign. We have a greater role in assessment and care. Many protocols are now saying oxygen delivery based on are now specifying O2 delivery based on their pulse ox readings. I'm sure you guys are familiar with the SpO2. By the way, can anyone tell me what SpO2 stands for? It's something that we use frequently in the field, but it's not always something that we know what it means. So anyone knows what SpO2 even stands for? Saturation of hemoglobin. Yes, the P stands for peripheral. But by the way, Phil, I think you're still sending me private messages, so I don't think other people are seeing them. So they're sending this is saturation, yes, is what the S stands for, of peripheral oxygenation. Now, realistically, we know that it's not measuring the oxygen content, it's just measuring the saturation of the hemoglobin. How much of the hemoglobin is soaked with, theoretically, oxygen. But hemoglobin can be soaked with something that it likes a lot more than oxygen, which is carbon monoxide. So it's not a perfect system by any means. So we also want to check blood pressure. Take an initial blood pressure manually and compare it with the non-invasive blood pressure. Non-invasive would be like the automatic one, but a manual blood pressure is best. I still believe in manual blood pressures if I think that the blood pressure is going to be a major concern for the patient, right? If we get back 2 bad readings, I'm going to take a manual just to confirm it because I want to own that blood pressure if it's really bad or really high. Finally, we're reassessing. Now, we always say 15 minutes on stable patients and every 5 minutes on unstable patients. Realistically, if you guys are going to go through the cognitive skills testing, all of our patients are going to be unstable. All of them are going to be reassessed at the 5-minute mark. Although, realistically, reassessments are a continuous process, not an every 5-minute process.